Dr. Julia Rowland is really one of the founders of survivorship, and she was appointed director of the NCI's Office of Cancer Survivorship in September of 1999. She was the founding director of the psycho-oncology program at the Lombardi Cancer Center at Georgetown University, and was one of the first 2 postdoctoral fellows at Memorial Sloan Kettering to receive NIH support training in the newly emergent field of psycho-oncology. Research has focused on both pediatric and adult cancer survivorship. She's published extensively on women's reactions to breast cancer, as well as the roles of coping, social support, and developmental stage in the patient's adaptation to cancer. She co-edited the groundbreaking textbook, Handbook of Psycho-Oncology, Psychologic Care of the Patient with Cancer, and is the author of more than 75 scientific articles, reviews, and book chapters. Since coming to the NCI, Dr. Rowland has been awarded an NIH Plain Language Award and was appointed as co-champion of the NCI's Extraordinary Opportunity in Cancer Survivorship. It is my enormous pleasure to have Dr. Rowland speak with us tonight. I think you'll all be incredibly thrilled and excited to hear her, and thank you so much for coming.
Again, my mother could have given that one. Thank you. Really, it's a pleasure for me to be here. Don't forget the bio now. Just that you ever heard any of those things, because we're going to kind of start from the beginning and give a little background. I've done something different for this talk. I love speaking to public audiences. I do a lot of professional speaking, but my feeling is we need to be making sure that you hear about where the science is going, particularly in this fast-moving field of cancer survivorship. So very special thanks to Dr. Axelrod for asking me, all of your colleagues here, for Dr. Myers for heading up the program, Rachel for getting me here, and doing all the legwork, putting a program like this together. So what I'm going to do is take you through a quick look at what we've learned from survivors over the years. So I'm doing something a little different than maybe what you thought you were going to hear when you came in here, which is I don't have a lot of solutions for you for some of the challenges you face, but I'm going to give you the 30,000-foot look at why this is important and what's happening at a national level about your well-being and what role you can have in that. So stay tuned. I don't have to apologize to this audience. Often when I speak down in Washington or other parts of the country, I make a short apology up front and say, well, I'm a native New Yorker, so I was born and raised here. As you heard, I went to Memorial Sloan Kettering, went to Columbia University. This is my backyard. My family is still here. But I've lived now in Washington a long time, but you can't take the New York out of the girl, so I speak really quickly, but I'm in the hometown. So you're going to get it. My feeling is, I don't have to tell you to buckle up and stay with me, because you're used to this rapid fire, and that's what we're going to do, because I'm going to fly through the material that I brought today. I don't have a clicker. Quick question to this audience. How many individuals in the United States today carry a history of cancer? No professionals answering this.
Personally?
How many what we call survivors? Are they people with a cancer history alive in the United States today? Yes, guess, number, throw it out. How many? How many? Anybody want to make a guess? How many?
1 million.
10? Let's see if I can get to this. Let's see. I'm going to get rid of that. Forget this. The answer is actually 15.5 million. 15.5 million people in the United States alone, not even worldwide figures, just the United States alone, carry a history of cancer. And that number has been rising steadily ever since 1971. Some of us can remember back when Nixon signed the National Cancer Act and declared what would soon be called the War on Cancer. In 1971, 3 million. Today, 15.5. In another 10 years, it's going to be closer to 20 million. And important in this, I'm not sure how well you can see the graphic, but that bottom line in there, the orange, those are individuals who are only a year out. So those would be individuals who are in active treatment, more or less, or close to it. But everybody else is post-treatment. We know that there's some individuals in those other bars who are struggling with side effects of their illness or might have had a recurrence. We actually can't tell you with our current statistics in the United States how many individuals have had a recurrence. It's a real problem in our database. We can tell you that of people newly diagnosed this year, 16% of them will have had cancer in the past. So multiple cancers are not uncommon. And in some ways, it's a high-end problem. People are living long enough to have more than one cancer. But the biggest driver going forward, what do you think is going to cause those numbers to go up rapidly in the next couple of decades? Anybody want to make a guess? Professionals, you can weigh in. So lack of knowledge, you think, so people are exposing themselves?
Technology.
Yeah. Technology that you think will cause the numbers to go up? Could be better screening, we're going to see more?
Genetics.
Genetics certainly contributes.
Boomers.
Yes, thank you. I hate to tell you that. All of us boomers blowing through the system here, pig in a python, we're going to drive those numbers up as we go forward. And about 15% of individuals today were diagnosed 20 or more years ago. We're going to see a huge influx of individuals 65 and older marching through, because for the most part, even though we look around and what we read about are the very poignant stories of young people having cancer, cancer is actually a disease associated with aging. So as we get older, we're at more risk for developing cancer for a variety of reasons. So with all of us boomers coming in the system, there are going to be a lot more survivors out there as we move forward. And that's something for us to be thinking about. So as I said, let's see, I'm going to see if I can get this clicker to work for me. Okay, as I said, we have, this is over time. You'll see that total, these numbers go down over time. And it looks like over time that females do better than males. We do. Sorry, we're just better designed. Homage to all of our males in the room. But I will tell you, as women's behaviors look more like men's behaviors, we work, we go to war, we're exposed to environmental toxins, we're going to look very much in our health like our male counterparts. So it's a sobering set of information for those of us who are women to be thinking about moving forward. As those numbers have gone up, as you heard Dr. Myers say, the Office of Cancer Survivorship, which is the office I have the privilege of directing, your office at the National Institutes of Health. So for those of you who don't know, the National Cancer Institute sits within the National Institutes of Health. It's one of 27 institutes and centers that comprise the National Institutes of Health. It is the biggest institute in that, with a budget of over $5 billion. And it is a research engine. So what we do is create, ideally, the evidence base for risk for cancer, preventing cancer, detecting cancer, treating, survivorship, end-of-life care. That's what it does. But as survivor population grew and individuals came back and said, well, what happens after treatment's over? What are the long-term and late effects? What are the consequences? That, in fact, in 1996, the Office of Cancer Survivorship, which was established at the NCI, and as you can see, the mission was to say it's not okay that people are just living longer. We want to be sure that the quality of life of those individuals is as best as it can be. And we need, in that process then, to understand what the late and long-term consequences are so that we can make better decisions around treatment and move that forward. And so we do this in three ways: promoting and directing research to look at the long-term and late effects and way to prevent or mitigate them, promoting training of researchers and clinicians to either study or deliver this care, and disseminating that information. So being here this evening is part of that mission. So I'm fulfilling part of the office's role by being able to share this information with you this evening. And this is my only political picture. So this is Clinton signing the ribbon of hope in a real Rose Garden ceremony that took place that actually was associated with the opening of the office back in 1996. And again, the person circled here is Ellen Stovall, who sadly died this past winter in January, long-term survivor herself of cancer, died actually of the late complications of her curative therapy for Hodgkin's disease, but 40 years after she was treated. So she was diagnosed just like a week before Nixon signed the Cancer Act, and went on to become the CEO and president of the National Coalition for Cancer Survivorship. So she's really one of our phenomenal leaders in this whole movement. And in fact, in the wake of the establishment of the office, a number of national reports appeared addressing what are the issues for survivors and their families. So the Institute of Medicine did 2 reports, one for children's outcomes and the other for adult. The President's Cancer Panel, which is actually an entity created by the National Cancer Act, and this is a a panel that provides information back to the President and Congress about how we're doing on the war on cancer, if you will. And the Centers for Disease Control and Prevention and Livestrong also did a report on this. So we have a lot of information about the long-term and late effects. And these are some of the lessons that we've learned. So I want to share with you what I think are some of the top ones. And first and foremost is language is important. So when the, let me step back. So back in 1985, a young physician, Fitzhugh Mullan, wrote a beautiful piece in the New England Journal of Medicine talking about his experience as a cancer survivor. He himself diagnosed on himself a fairly aggressive seminoma, so a version of testicular cancer, and had very aggressive treatment for that. And as he got through that treatment, he then wrote about his experience of being a survivor, what it was like. And he saw this as having seasons. So he talked about the acute survival in the middle of all of this diagnosis and aggressive treatment. Then he talked about extended survival, kind of that period post-treatment when you're waiting, is it going to come back, what's going to happen, holding your breath, and then to this, what he referred to as extended survival. But that document, many of us feel, gave us the first language for thinking about survivorship. And he took that and with 24 other individuals created the National Coalition for Cancer Survivorship in a meeting in Albuquerque, New Mexico. And their first task there was to tackle the language, because in 1986, to be a cancer survivor, at least in the United States, you had to be 5 years disease-free, okay? And they said, well, you know, it's 86. Most people are diagnosed are going to be here beyond 5 years. We can't wait 5 years to figure out how we're going to pick up the rest of the pieces of our lives and move forward. I can't wait 5 years to decide, gee, I think I'd like to have children, and find out it's too late because your options have now been removed. Or that you wanted to be a dancer and maybe limb preservation would have been important to you. You can't wait that long. So what they did in a very radical move is they redefined what it meant to be a cancer survivor. That's Fitzhugh in the front. And they said, we think that we're going to call a survivor an individual who has a cancer diagnosis from the moment of diagnosis going forward, irrespective of what happens in that trajectory. And under that umbrella, they also, because I'll come back to this, put caregivers or family members as like secondary survivors, because they know how important a role family plays in the well-being of individuals who are diagnosed and treated. It's very important when we think about this, because as you remember, I said the lesson learned was language is important. They didn't mean this as a label. And a lot of people really find it very offensive. I don't think of myself as a survivor. I had a heart attack. I don't think of myself as a heart attack survivor or a diabetes survivor. Why are we labeling people with a cancer history? They never intended it to be a label. What they really intended was two things: a message of hope. There is life after cancer, very important message. And the other was, you need to be thinking about that life at the time of diagnosis, before you make those decisions about what you want to do moving forward. Very revolutionary, and I will say in this country, it changed practice. I think it has had an enormous impact on the philosophy of care that we deliver today. We don't expect people to put it on hold. We do want to have those conversations. What's important to you? How are we going to tailor your treatment? I will tell you, with new precision medicine moving down the pipeline, those conversations are going to become even more important today and tomorrow than they were in the past, because treatment's all going to be all about tailoring to the individuals, and not just your genome and your metabolome and your genomic level, but who you are, what's important to you, what do you want to do after cancer, what would your treatment alter, can we tailor this therapy to you? So I'll give you my classic example, to date. I'm always open for new ones. So a woman I met in a support group who was in her early 40s. She came with her seeing eye dog. She had been blind from birth, and she had been treated for breast cancer, and she shared with the group her story. And she said when she came in for treatment, she had a conversation with her medical oncologist, and her medical oncologist said, because of the genetic information I have and your tumor markers, I think it'll be very important for you to get chemotherapy, and I would like to give you a regimen that includes the drug Taxol. Well, this woman said, doctor, I've done my homework. I understand that there is a high risk for individuals who receive that therapy to develop what's called peripheral neuropathies, or having trouble with feeling in your fingers and your bottoms of your feet. And she said, doctor, I read Braille. I need to know where my dog is next to me. I need to feel my feet on the pavement. And you could hear in her conversation, you could almost hear a light went off in her medical oncology's head. And they took that drug out of her protocol, and she's doing fine. I mean, it's because that would have been life-altering for her, that toxicity was not acceptable for her. For somebody else, perhaps not, but in her case, that was a very important, good-bad balance for her to talk about. At a minimum, what the coalition wanted to do is get rid of that term victim. And I'm happy to say, if you are like me, it's my Irish Catholic background, I read the obits. We now talk about cancer. People actually die of cancer, not the big C or a lingering illness. And actually, sometimes they die quite graphically of cancer in the paper. But you don't hear the word victim. And I think that is a great gift, not to have people labeled as a victim of their disease. So language matters. My only other pet peeve for my medical colleagues in here, patients do not fail therapy. Our therapies fail to help our patients. We're still working on that one because physicians and other clinicians still say patients failed the chemotherapy and we're moving to the next drug. Patients don't fail, I'm sorry. Second important lesson that we learned is that being told you're cancer-free does not mean you're free of the cancer. In fact, as many survivors will say, it's not over when it's over. I've just now moved to this other phase. And that's very important because cancer can affect virtually every aspect of an individual's life: physical, psychological, social, economic, existential. Some of these effects go away pretty quickly. We refer them as acute, nausea, vomiting, hair loss, reverse fairly quickly when treatment ends. Others turn out to be more persistent and insidious: fatigue, memory problems, sexual dysfunction, pain syndromes, body image changes that don't ameliorate over time. And some, in the medical world, is often very worried about the late effects, certainly second malignancies or recurrence. But now as we watch survivors live longer, we're worried about complications like cardiac problems or bone health or diabetes or other kinds of end organ compromise that may have been either caused by or accelerated by the cancer experience. So very important in here. And what it means in the care spectrum is we've got to figure out who's at risk. Often we don't know very precisely who's going to develop these toxicities, who's going to have chemotherapy-induced peripheral neuropathy, who's going to have fatigue that goes on for months at a time, who's going to suffer from memory problems. We're not really good yet at identifying that, but now that we acknowledge it occurs, the research community is headed that way, is trying to say, okay, who might be at risk and what can we do to prevent that from occurring or address it right away so that problem is minimized. And also, how are we going to look at that for monitoring people? So if you're post-treatment, what do I need to be looking at long-term, and what do you need to know about that as you move forward? The third lesson we've learned, and again, for those of us who have the privilege of working with patients and their families, is the remarkable, remarkable resilience of human beings. You know, you sit back and you say the arduous treatment we put our patients through and that they tolerate and they get through, hook or crook, whatever it takes, and come out the other side, sometimes stunning even themselves. It is, to me, very humbling to see people do this time and again. Most people do remarkably well. That doesn't mean that a fair number don't struggle along the way. Some 50% of individuals at any given time will tell us that their distress levels are enough that we need to ask more than how are you doing. And about a quarter of third of those individuals probably need more intensive care. So we're learning that. And that means talking to a therapist, maybe getting a social worker involved, having a chaplain, having additional supportive services, whatever that's going to take, to make sure that that person has in place the resources and skills they need to make it through. The good news is we have a lot of interventions that are evidence-based that work. The problem is we're not applying them. So if you have anxiety or depression, the concern we have is, are we getting to everybody who needs that kind of help? And the Institute of Medicine did yet another report released in 2007 saying, no, we're not doing a good job here. We're taking care of the body, but we're not doing such a good job with the emotional part of this. And so they laid out an algorithm and said everybody at every institution needs to be asking about that, including here at NYU. We need to be screening for distress and referring people to services as appropriate, and most importantly, following up to see if our referral did anything for you. And to me, that's actually the most vexing from a clinical point of view. We're pretty good, we can do screening and we can do a referral. What we're not quite got together is, are we making sure that we come back and we ask, did it work? Was that helpful to you? Did you fill a prescription if we gave you one? Did it help you? Did it give you side effects? Did you throw it out? Was it too expensive? You didn't buy it? Is it not working for you? Did I make the wrong referral? The bottom line is we need to come back and say, did I help you? Did we fix this? Because if not, we've got to come back and try another solution. And I think I say that to you because you're in a position to ask for those resources, to say, doctor, you told me this, you referred me here, it didn't help, it didn't work. And if you don't tell us, we don't know. So we can't change it for you. So that's got to be a dialogue. So I want you to be thinking about that, because our problem in the larger picture is trying to figure out who needs what, when in the course of care delivered by home. And of course, in the US, because we don't worry about this in other countries where it's socialized medicine, who's going to pay for this? It's a chronic problem for us, but it's ours to deal with. And it should be part of care. It shouldn't be, oh, we'll give you everything else and then we won't do the psychosocial component. That is simply not acceptable. Lesson 4 we've heard from survivors is that cancer can provide a teachable moment. A moment in time when people come in and say, I've had this experience, I never want to do this again, ever. And I want you to tell me, what can I do to keep this from coming back? What can I change the behaviors I've engaged in? Should I change my diet? Should I exercise more? Should I do the green tea? Should I go see a chiropractor? What should I be doing? How can I be involved in my care? And I think that's really very true for lifestyle and health behaviors. And we're concerned about that on the delivery side because we have a growing number of survivors. They're living longer, so they're at risk for other kinds of health conditions. Many of them are older and aging, and we're all kind of along that trajectory. We know they're at risk either because they came in with some other chronic condition and we treated them and exacerbated that underlying condition, or we've now induced a condition because of the nature of the treatments that we've delivered, and therefore we have to worry about it. And many, I think we forget about this, many of our survivors are not going to die of their cancer. They're going to die of some competing illness or condition. And heaven forbid we do a great job of curing your cancer and letting you die of heart disease because we didn't counsel you on the risk factors that we could have intervened to address. So that's something to be thinking about, and I think your practitioners are beginning to. We also worry about weight gain or the opposite, really extreme weight loss in the course of care. The fact that people often stop exercising in the middle of their treatment because they just are too tired or they feel they can't do it. It's trying to keep people active as much as we can through treatment. And we've heard that the quest for this, help me do this. And we know that a healthy lifestyle can help in a lot of fronts. We're not always able to say, if you run 5 miles a day, your cancer will never come back. Or even if you walk 5 miles a day, or 5 miles a week, or 10 minutes a day. We can't guarantee that your cancer won't come back. But we can certainly tell you that it's going to help you be healthier. And if your cancer were to come back, it's going to make your treatment easier because you're going to be better shaped to receive that. And we're doing the studies, that we're funding some studies now that are going to be looking at weight loss and physical activity as an intervention for recurrence. We're using a breast cancer model, but we'll see. So it's an empirical question. The observational data look very good. Survivors who tell us they're more active after treatment live longer. We just don't understand the mechanism and what should the prescription be for each individual. Here's the bad news, and that is while most of our survivors are reducing their smoking or their rates are going down, paralleling those in the United States, we have worrisome data to tell us that our young survivors, those 40 and younger, are smoking at high rates. I'm actually looking at my medical colleagues here because that's your job. Heaven forbid we have someone in front of us and we don't ask and refer. That's just not okay for me, and I often will tell people when I go to a cancer center like NYU, and I will say, you're lucky I don't work in the centers branch at the NCI. So the NCI funds big centers. NYU is one of them, big comprehensive centers. And when we do that, we require them to have certain standards. we do not require that they screen for tobacco use and refer. If I ran the zoo, I would actually make that a criteria.
Yeah,
We do.
We actually do.
All right, go NYU.
We can't go forward in our electronic chart unless we address that.
And my feeling is that's a great solution, because if we don't bake it into the system and make it so that you can't move,
It's embedded.
that is fabulous to hear. Yes, please.
I mean, okay, this may sound a little bit controversial, but I don't believe that smokers should be so, I believe that cancer prevention should be all cancer survivors, not just for smokers.
No, I absolutely. I'm just saying that these are survivors who told us they're smoking. Who said, that's just the ones who told us. And we know there's underreporting by people who engage in behaviors that they feel socially are not acceptable. So if anything, this is an underestimation. That's a worrisome figure. So it could be, and any number of reasons, but we have good interventions. And I'm just saying this is that teachable moment when clinicians, and clearly NYU has a capacity to do that, is ask and refer.
I'm
Because
actually speaking from a point of prevention.
primary prevention we should be doing, and actually the United States has been a leader in that. When you look at our smoking levels, although I will say on a big blot on our report card, because I work for you and I work for the NIH campus, so, and I'll remind you that the Surgeon General's report on smoking came out over 50 years ago. We've known for over 50 years that smoking was bad. We now have bans in public spaces and et cetera. The NIH campus did not go smoke-free until 2008. Shame on us. The National Institutes of Health. Okay, so it's not always easy to move tankers, but we need to keep doing it. And certainly there's a lot of data out there to say that if we could get the entire country to stop smoking, hundreds of thousands of deaths of all, not cancers, just among the diseases that is associated with smoking. But work we have to do, and of course we're now worried about the sweeping obesity epidemic that's certainly visible in the United States, and what this is going to do to cancer risk and the well-being of our cancer survivors. It's making us ask, how can we leverage the experience to help people engage in healthier behaviors without feeling punished? I mean, I don't want to feel guilty for my behavior, but I want the opportunity to change it as I'm ready to do that. And what should we be recommending with diet, weight, and physical activity? I will say we need to tailor this. If I know that a patient has received a chemotherapy that has cardiac effects, I want to be sure that individual is going to be engaging in physical activity that doesn't put him or her at greater risk for cardiac complications. So I'm not going to blanket tell somebody to go out and do something without the appropriate and thoughtful assessment of what's going to be best for that person, and tailoring as needed. So the fifth lesson we've learned loud and clear, and that'll go back to that original definition where the coalition said, family members are secondary survivors. They're doing this journey alongside, and we often forget about them. They come to clinic, and yet they're not part of our comprehensive care. We somehow don't worry about them, and yet we count on them. My favorite quote in this arena is that by Rosalind Carter, so Jimmy Carter's wife, who is really a champion of caregiving and caregivers, who basically said that there are only four kinds of people in the world: those who've been caregivers, currently caregivers, will be caregivers, or who will need. So we're all in this boat. We don't get out of this boat without being in one of these roles, basically. And yet we forget about it. So one of the challenges we have in the system is, how are we going to address the needs of family and help that benefit everybody? We have data from a large study we conducted called CANCORS, the Cancer Care Outcomes and Research Surveillance Consortium, where we looked at a large sample of lung cancer patients and colorectal cancer patients and followed them across the course of their care, and then solicited participation by their caregivers. And what we heard from the caregivers is they were providing a lot of care. More than a third who were providing more than 20 hours of care, 13% more than 8 hours a day. Many of them reported role conflict and strain because there might have been kids at home or they're balancing a job, trying to manage all of this. Many also indicated that they wanted training in what they were doing but didn't receive it, or were doing tasks that they felt they weren't comfortable doing because they'd had no feedback on how it was. And many of them also, so you think of caregivers and our survivors as older, are older themselves and struggling with their own health conditions. So this is a vulnerable population. And so the challenge back to us in our community is, can we intervene with families? Can we actually take care of these partners, if you would, going through the experience and help both? So that if we intervene with caregivers, it's going to benefit patients. If we intervene with patients, everybody's going to do better. How do we do that? And how can we perhaps use this teachable moment for family? Because if we're going to do a dietary intervention with a patient, we need to be looking in that refrigerator at home and who else is eating what to say, is this really going to be reasonable to do if the behavior at home is going to undo any good messaging we want to have, or make it difficult for a survivor to engage in healthier behaviors. And then the sixth lesson we learned, perhaps most important for this evening, is that transitioning to recovery is really difficult. People come to the end of their treatments and they're so excited, and rightfully so, to have gotten through all of this. And then they'll turn around and they tell us, and then I felt pushed out the door. I felt abandoned because they kind of gave me this care plan and said, good luck with that. Bye. Have a nice life. Oh, and here's someone you could talk to. And it's stressful for a variety of reasons. Obviously, there's that fear that once you stop treatment, the cancer's going to come back. You know, you're sort of waiting, holding your breath. Did it really do the trick? Is it really over? There's not, although I think it's beginning to be with this whole survivorship care plan movement, preparation for what comes next. There is concern about who's going to do the monitoring. You know, I had my fellow and my nurse and my physician I could call. I know I had their numbers on my refrigerator if I knew what symptoms to look for and who was in charge, and I knew that there would be someone available to me. And now what? I don't feel I have access to those people. Who am I going to call? Who's going to be taking care of me? I also came to the clinic and I had all my fellow travelers with me, and that was really a support group for me. And the staff knew what I was going through, and my fellow travelers knew what I was going through, and my family doesn't get it. You know, they're so glad this is over. They want me to go back and do all the things I was doing before and be that person I was before. I'm not that person that was before. It's not necessarily a bad thing. I'm just different. And I need time to recover. I used to, in my clinical practice, used to tell the patients I saw, I think you have to think back from the first symptom you had. First time you suspected or were told you have cancer, and add up all the time till your very last treatment, however many of that, weeks or months, whatever that is, let's say 6 months. You have to estimate that it's going to take you a day-for-day recovery, and plan that in. Because if you think I'm going to be fine in a week, it's a setup for failure. And we don't want you to fail. We want you to feel that you're progressing in here, but you need time to do that. And giving yourself time, and your family needs to give you time, because recovery takes time. And certainly when patients leave treatment, they're often feeling worse than we brought you in here. Ironically, you know, you was feeling pretty good until you had treatment, and now you feel pretty terrible. And there may be financial factors in here. You're just ready to be out of here, back at work, or whatever it is you need to be doing. So a lot of pressure, and often surprises survivors as they make that transition. But the good news is there's been huge public visibility to this. So the Institute of Medicine report, President's Cancer Panel, all of these documents came out and said, from the advocacy community, we think survivors need two things: treatment summary. You need all the details of what went on, the tumor markers, etc., all the different treatments you had and who provided them and what complications there might have been on a document. And the companion piece to that is a follow-up care plan. These two documents together, and there are two parts to that. You have to have a treatment summary that's then used to populate the follow-up care. Together, that's what we refer to as a survivorship care plan. If you don't have one, you should. Survivorship care plan. So what goes into that? It has basically 4 big components. The Institute of Medicine outlined 11, but these can be summarized down into 4. Surveillance for recurrence. So what are you looking for a cancer if it might come back? You know, what you should be doing in that regard. You should have had some kind of an assessment and treatment or referral for persistent effects. So if you have pain or fatigue, or you have employment issues, whatever those are, those have been assessed and appropriate referral has been made for those. There should have been some kind of evaluation for risk and a plan for prevention of late effects. So if you're at increased risk for a second cancer, that you know what that is, what the screening is going to be for that, what you can be doing, or if you're at risk for compromised bone health, what you should be doing for that. And as part of this, all indications on health promotion, what can you be doing, what lifestyle behaviors can you engage in to reduce your risk. And perhaps the most important piece in here, in our very fragmented care systems, coordination of care. Who's going to do this? And this is going to become a growing issue because here you have a wonderful survivorship clinic and programs evolving, which are terrific. There is a national question mark about who should be delivering this care. You heard me say there's going to be this silver tsunami coming into the cancer arena with older folks. We're going to really broaden the number of people in the system who need care. There are going to be fabulous institutions like NYU who are going to be struggling to keep up with new patients coming in and moving folks out the door. And then we have a big push to say, can we take some of our folks and take them right back into primary care? And that makes a lot of sense if somebody's had very early stage cancer and they're older and may have been already being cared for their cardiac health, their diabetes, or hypertension in the community. And part of the push now is training primary care providers to be comfortable following cancer survivors, realizing that you may want your oncologist available as needed, but that actually your care is better delivered by primary care, who's going to be looking at the rest of your body parts. They're not stuck on your colon or your breast or your lung or whatever body part it was you had treated for your cancer. They're taking into their frame your whole person. So they're looking at your health behaviors. They're looking, did you get your flu shot? Do you need any other vaccines? Or are you due for some other exam in here? Whole person care. Your oncology team does not provide that. They do a fabulous job with the cancer and surveillance side in here. Primary care are the physicians who are best suited to deliver the rest of the care. So that's a challenge, and if you don't have a primary care physician, it's something you should definitely be thinking about, and how to do that coordination of care. And believe me, it's a national struggle. We're struggling with trying to figure out how to make those transitions because we all get attached to our providers. And I may never want to leave my surgeon. I always want to go back and see my surgeon. But practically, for the rest of me, I need to go and see a primary care physician to make sure that I'm not missing any opportunities for wellness. As I said, lots of pressure on this. The Affordable Care Act has made many of these services more available. I will mention two bodies here that have had a big role in here. The American Society of Clinical Oncology, which is a huge organization, 37,000 plus members, largely medical oncologists, so all the folks who deliver your chemotherapy, hormonal therapies, are practitioners in there, but it has a lot of other diverse members. They have quality indicators, and among their quality indicators are whether a treatment summary was given to every patient. They also have a quality indicator for screening for distress. These are voluntary programs at the moment. However, the American College of Surgeons Commission on Cancer, which certifies cancer centers like the NYU Center, so this has teeth in it. For them to pass certification, they have to show that they're screening every patient for emotional distress at some seminal point in the course of care and do something about it, presumably, and also assure that individuals finishing treatment are receiving survivorship care plans, which I know is already being worked on now. So there's a national push, and this actually came out of advocacy. It didn't come out of the medical community. They didn't come in here and say, oh yeah, let us do treatment summaries and care plans. No. It was survivors saying, hey, I need this information. I need to take it with me. You guys got to summarize it all up. I need something because I go see all these other providers, and I can't be here telling them my story. I need this in a summary fashion, and I need guidance about what should that care look like. That's where it's going. And I think it's a huge and important movement for everyone. And I think what it's doing in here is making us realize that fundamentally at the bottom of all of this, we have to change the culture of research and care such that the person is as important as the tumor and maybe even more important than the tumor when we deliver care. And I think we're at a fabulous moment in time because we have significant advocacy, we have lots of voices standing up and arguing, demanding better care. We have a greater focus on care systems now and delivering optimal care and coordinating that. Technology, the new EHRs, hopefully, I'm not believing this has happened overnight. but we're working on it so that this will be baked in to systems in here. We have more researchers and clinicians, and we certainly have a big advocacy community. And I would say that the last and probably most important lesson we've learned, certainly I know in my practice I learned, and that's that we have to listen to survivors. We need to know what your concerns are for us to address them. And if we don't, we know that there are going to be challenges for us. And when we do, there can be amazing life after cancer, but only if we work together as a team and bring all the resources to bear to help ensure that people have high quality outcomes. So I'm going to stop there. This is the website for the Office of Cancer Survivorship, full of resources. Also, please feel free to let us know if there are things up there should be up there and things you want to know about, because this is your office, your tax dollars that support this. So thank you.